Welcome to the deep dive. Just take a moment and picture the incredible raw power, the whip-like speed, and the astonishing precision needed for overhead sports.
Hmm.
Imagine a perfectly thrown fastball scorching towards home plate. The sheer devastating force unleashed in a professional tennis serve. Or, the relentless, fluid, almost hypnotic motion of an elite swimmer cutting through the water.
Yeah, it's amazing to
It
watch.
really is, pushing the human body to its absolute limits. But that same intensity, that same drive for peak performance places tremendous, almost unbelievable stress squarely on two key joints, the shoulder and the elbow.
That's right. And for anyone involved in these activities, whether you're an athlete yourself, a coach, a parent, or maybe just someone fascinated by the mechanics of the human body under extreme load, understanding why and how these joints are vulnerable is, well, it's absolutely critical.
Definitely.
In this deep dive, we're going to unpack the complex world of injuries common in these overhead athletes.
Our mission today is to act as your guides. We've taken a stack of detailed expert sources on this very topic, and we're going to try and cut through the complexity, extract the most important insights, maybe some surprising facts, and the core knowledge you need. We're here to provide you with a clearer picture of the unique biomechanical challenges these athletes face, the specific problems and injury patterns that commonly arise, how they're diagnosed using various tools, the range of treatment options available, both non-surgical and surgical, and, crucially, the fundamental principles of getting these athletes back to their sport through rehabilitation.
Exactly. We'll be covering the full spectrum, drawing directly from the information provided in the material we have here. We'll start with the fundamental physics and mechanics of how an overhead throw or motion even happens, delve into the intricate anatomy and stabilizers of the shoulder and elbow, and then zoom in on specific issues you hear about, like tears in the rotator cuff or the elbow's ulnar collateral ligament, complex problems with the shoulder labrum, like SLAP lesions, issues with how the shoulder blade moves scapular dyskinesis, and even conditions affecting the bone itself, like osteolysis or OCD.
Okay, so quite a range. All right, let's jump right in and start with the shoulder, because the forces it endures during an overhead motion are, well, they sound nothing short of astronomical.
They truly are. When we talk about overhead throwing, we're not just talking about generating speed, we're talking about incredibly rapid movements that also have to be stopped.
Right, the deceleration part.
Exactly. Think about the moment right after the ball is released. The arm is still moving at tremendous velocity, and all that kinetic energy needs to be dissipated, absorbed by the body.
Okay.
Experts estimate that during the deceleration phase of a baseball pitch, the angular deceleration at the shoulder can reach an astonishing 500,000 degrees per second squared.
500,000 degrees per second squared? That number is hard to even wrap your head around. What does that level of force actually mean for the body?
It means the structures around the shoulder, joint the muscles, tendons, ligaments, the capsule, are absorbing immense energy to slow the arm down safely and controllably. It really brings you back to foundational physics, doesn't it? Like Newton's laws of motion.
Absolutely. It's not just abstract concepts. They're fundamental to understanding these injuries, in a practical sense.
Precisely. Take Newton's third law.
Yeah.
For every action, there is an equal and opposite reaction. So when the muscles generate force to accelerate the arm, the body experiences reactive forces. When the muscles stop the arm, eccentrically contract, the body experiences equal and opposite deceleration forces. These forces are transmitted through the joints and soft tissues. If the body isn't equipped to handle them, or if they are applied repetitively over and over, well, something has to give eventually.
So the shoulder isn't operating in isolation then. It's part of a bigger system, a chain.
It's exactly right. This is where the concept of the kinetic chain becomes absolutely vital. Effective, and importantly, injury-resistant overhead motion starts far away from the shoulder itself. It begins with generating power from the ground, the legs, the hips, and particularly the trunk, or the core.
Okay.
This energy is transferred sequentially up through the body to the arm. Think of it like cracking a whip. The flick starts at the handle and the speed builds exponentially towards the tip.
So if an athlete has weakness or maybe poor coordination in their legs or core, that energy transfer is inefficient. Does it break down?
Exactly. If the lower body and core aren't generating and transferring enough force, or maybe if the timing is off even slightly, the upper body, specifically the shoulder and elbow, has to compensate.
Ah, okay.
This puts excessive stress on those later links in the chain, forcing them to work harder than they were designed to, especially during those high-force acceleration and, crucially, deceleration phases.
And the shoulder blade, the scapula, plays a unique role here too, I understand?
A crucial one. The scapula isn't just a static bone, it's a dynamic part of the shoulder complex. It needs to move in a coordinated way on the rib cage, protract, retract, rotate upward to provide a stable base. Think of it as the launch platform for the humerus, the upper arm bone.
Right, a platform.
This stable platform allows the humeral head, the ball of the shoulder joint, to rotate through the extreme ranges of motion required for overhead activities, without putting undue stress on the static stabilizers like the ligaments and capsule. If the scapula's movement or stability is compromised, a condition often called scapular dyskinesis, the mechanics of the main shoulder joint, the glenohumeral joint, are disrupted, significantly increasing the risk of injury.
It makes sense. Now, experts often break down the overhead throwing motion into distinct phases to analyze the mechanics. It happens incredibly fast, less than 2 seconds total, apparently, but there's a lot going on in that short time.
There's tremendous complexity packed into that brief window, absolutely. The phases typically described are the wind-up, early cocking, late cocking, acceleration, deceleration, and follow-through. The wind-up and early cocking are really preparatory, getting the body and arm into position. The arm elevates to about 90 degrees of abduction, maybe a bit more. Muscles like the deltoid and the rotator cuff muscles, supraspinatus, infraspinatus, teres minor, start engaging.
Late cocking feels like the point of maximum load, almost like stretching a rubber band to its limit.
It really is. This phase culminates in maximal external rotation at the shoulder, often reaching 170 to an incredible 180 degrees in elite throwers.
Wow.
At the same time, the scapula retracts and rotates upwards, helping to stabilize the shoulder in this extreme position. Critically, at this point, the humeral head actually translates forward slightly on the glenoid socket. Muscles like the supraspinatus, infraspinatus, and teres minor are working intensely here, contracting isometrically or slightly eccentrically, and the subscapularis, a powerful internal rotator at the front, starts preparing for the next phase, building up elastic energy.
Okay, then acceleration is the explosive part, the release.
Yeah, right. It's a very rapid transition from that eccentric pre-stretch to powerful concentric muscle activity. The shoulder internally rotates at tremendous speed. The scapula protracts, moving forward around the rib cage, maintaining that stable platform as the arm whips forward. Big muscles like the pectoralis major, latissimus dorsi, and the serratus anterior are driving this explosive motion.
And then immediately you have to slam on the brakes, stop all that momentum. That leads into deceleration and follow-through.
Yes, and these are arguably the most demanding phases, biomechanically speaking. They rely heavily on eccentric muscle contractions, that's muscles lengthening while under tension, to slow the arm down safely and prevent injury.
Right, lengthening under load.
Experts consistently point to the deceleration phase as having the absolute highest forces acting on the shoulder joint. This is when the rotator cuff, particularly the posterior rotator cuff muscles like infraspinatus and teres minor, is under maximum stress and most vulnerable to injury due to that massive eccentric load.
So it's not throwing the ball that tears it, it's stopping the arm after throwing.
Very often, yes, or at least that's where the cumulative damage really occurs. Any kinetic energy that didn't efficiently transfer to the ball has to be absorbed by the athlete's arm and body. And if the core and lower body haven't efficiently dissipated energy earlier in the kinetic chain,
Then the shoulder and elbow take the hit?
precisely, the forces landing on the shoulder and elbow become even greater here. Muscles like the teres minor, posterior deltoid, and middle deltoid are highly active in deceleration, working eccentrically. The teres minor, a key posterior stabilizer, actually shows some of the highest activity levels of any shoulder muscle during this phase.
Interesting.
This makes the posterior joint structures, the back of the rotator cuff, the posterior capsule, particularly susceptible to injury during deceleration. The torque, the twisting force on the humerus during deceleration, can reach values around 15,000 inch-pounds.
15,000 inch-pounds. Can you put that in perspective?
Well, it's difficult to make a perfect analogy, but imagine trying to stop a 1,250-pound weight that's attached to a 1-foot lever arm connected to your shoulder. That's the kind of force those muscles are dealing with, albeit very briefly.
Wow. Okay, that really makes those deceleration forces tangible. So what are the key structures actually holding that joint together and allowing that incredible motion under such extreme stress?
You have both static and dynamic stabilizers working together. The static stabilizers are primarily the ligaments, the joint capsule, and the labrum, that cartilaginous rim around the socket. The inferior glenohumeral ligament complex, or IGHLC, is absolutely critical for stability.
The IGHLC, okay.
Within this complex, the anterior band of the IGHL is considered the most important static restraint against anterior instability, the shoulder sliding forward, especially when the arm is abducted and externally rotated to 90 degrees.
Which is exactly the position of peak stress in late cocking, right?
Right. Exactly. In that position, the anterior band is tight. Conversely, the posterior band of the IGHL is tight in abduction and internal rotation, providing posterior stability.
Mm.
And the axillary pouch, the sort of hammock-like portion at the bottom, also contributes to stability, particularly against inferior translation.
Can these ligaments get stretched out or damaged just from repeated throwing, not necessarily a single big traumatic event like a dislocation?
Yes, absolutely. That's a key point experts make.
Yeah.
With a recurrent instability, even if it's just micro instability or repeated subluxations, that repetitive microtrauma and cyclic overloading can cause plastic deformation in the IGHL.
Plastic deformation, meaning it stretches and doesn't fully snap back.
Precisely. The ligament stretches slightly and doesn't fully return to its original length. Now, the reported permanent stretch might sound small in some studies, maybe less than a millimeter.
Yeah.
But even these seemingly minor changes in ligament length and tension can significantly impact the joint stability and kinematics over time. Research has actually shown a direct positive linear correlation.
Yeah.
The longer the anterior band of the IGHL becomes, the more external rotation is possible at the shoulder, and importantly, the greater the anterior translation or forward sliding of the humeral head on the glenoid.
So a little stretch leads to a little more wobble, which can add up. What about the dynamic stabilizers, the muscles?
The rotator cuff muscles are your primary dynamic stabilizers. They do much more than just move the arm. They work synergistically to actively center the humeral head on the relatively small and shallow glenoid socket. This crucial mechanism is called concavity compression.
Concavity compression.
Yes, by compressing the ball, humeral head, into the concave socket, glenoid, and maintaining a balanced force coupled between the anterior subscapularis and posterior infraspinatus teres minor cuff muscles. The rotator cuff provides dynamic stability throughout the entire range of motion, preventing excessive translation or shearing of the humeral head, especially during high-velocity movements.
Got it.
And we can't forget the scapulothoracic muscles, the ones controlling the shoulder blade. They are absolutely essential dynamic stabilizers too. If they are weak or not firing correctly, leading to that scapular dyskinesis we mentioned.
The platform is unstable.
Exactly. The glenohumeral mechanics are compromised, the rotator cuff has to work harder to compensate, increasing its own risk of fatigue and injury.
Given these extreme forces and all this repetitive motion, it's no wonder certain specific overuse patterns develop, often described under the umbrella of impingement.
Right, and one key pattern specifically seen in overhead athletes is internal impingement. This is distinct from the classic subacromial impingement you might hear about more often in, say, older individuals with bone spurs. Internal impingement happens within the joint itself.
Okay, inside the joint. How?
Specifically, it occurs when the undersurface, the articular side of the posterior rotator cuff tendons, typically the supraspinatus and infraspinatus, makes physical contact with the posterior superior rim of the labrum and the edge of the glenoid socket.
When does this contact happen?
It happens during that position of maximal abduction and external rotation, the late cocking phase of throwing.
So the rotator cuff is literally getting pinched between the humeral head and the back top part of the socket rim.
Precisely, but it's the underside of the cuff hitting the back top of the socket and labrum in that extreme end-range throwing position. This repetitive contact, this microtrauma, can lead to irritation, fraying, inflammation, and eventually partial thickness tears developing on the articular side of the rotator cuff.
Ah, okay.
It can also cause damage to the posterior superior labrum itself, often contributing to or occurring alongside SLAP lesions, which we'll get to. Internal impingement is strongly associated with other factors like posterior capsule tightness and some degree of anterior laxity, often linking back to that GRD phenomenon.
And the symptom an athlete might feel from this?
A classic symptom is posterior shoulder pain. Pain felt deep in the back of the shoulder, specifically reproduced when the athlete's arm is placed in that late cocking or early acceleration position. Experts also note that muscle fatigue, maybe later in a game or practice, can lead to slight changes in throwing mechanics and potentially increase angular velocity, which could exacerbate the severity of this impingement.
Now, there's also a specific impingement pattern that happens down at the elbow in throwers caused by those same valgus forces we mentioned earlier.
Yes, that's valgus extension overload, or VEO. The repetitive valgus stress of throwing that force, pushing the forearm outward relative to the upper arm, can over time lead to laxity or stretching of the ligaments on the inside, the medial side of the elbow, primarily the UCL.
Okay.
Now, as the elbow straightens out rapidly during the throwing motion, this increased valgus laxity allows the back part of the ulna bone, the olecranon process, to repeatedly impact against the humerus bone in the posteromedial aspect of the joint.
So bone hitting bone in the back inside part of the elbow.
Exactly. This causes chronic irritation and often leads to the formation of bone spurs or osteophytes on the olecranon. This posteromedial olecranon impingement is noted in the sources as being a very common surgical diagnosis in baseball players. It causes pain, clicking, and sometimes locking in the elbow.
Another phenomenon that seems strongly linked to all these throwing mechanics is GRD, glenohumeral internal rotation deficit. You see this talked about a lot with throwers.
Yes, GRD is almost an expected adaptation, you could say, in many high-level overhead athletes, but
Yeah.
it can definitely become pathological and contribute to injury. It's generally defined as a loss of internal rotation range of motion in the throwing shoulder compared to the non-throwing side. The cutoff varies slightly, but it's usually considered significant if it's greater than, say, 20 or 25 degrees difference.
What's the underlying cause? Why does the internal rotation decrease?
The primary cause experts point to is tightness, or contracture, developing in the posterior capsule of the shoulder joint and potentially the posterior band of the IGHL. Basically, the tissues at the back of the shoulder get tight and shorten from the repetitive stress of deceleration.
Okay, so the back of the shoulder gets stiff or shortened. How does that actually affect the movement, the kinematics?
This posterior tightness acts like a tether and disrupts the normal mechanics, especially during that critical late cocking phase where the arm needs to achieve maximal external rotation. Because the back is tight, it restricts the normal posterior glide of the humeral head.
Right.
So to compensate and still achieve the required layback or external rotation, the humeral head can be forced to shift abnormally, often posterior superiorly, that's backwards and slightly upwards on the glenoid socket.
Okay, so it shifts into a slightly different spot on the socket.
Correct. And this abnormal shift then puts increased strain and stretching forces on the anterior capsule and ligaments, particularly the anterior band of the IGHL.
So tightness in the back actually leads to stretching and potentially laxity in the front. That's counterintuitive.
It is, but that's exactly the mechanism proposed. And this posterior-superior shift also has consequences for the superior labrum and the biceps anchor attachment right at the top of the socket.
How so?
As the arm moves into maximal external rotation, with the humeral head shifted backwards and upwards due to the posterior tightness, it can cause the superior labrum, along with its biceps tendon attachment, to literally peel away or lift off the underlying glenoid bone.
Okay.
Experts call this the peel-back progression mechanism. This specific mechanism is strongly implicated in the development of those articular-sided rotator cuff tears we talked about, as the shifted head impinges differently, and critically, in the formation of SLAP lesions.
Wow. So GRD isn't just a simple lack of internal rotation. It actually sets off this whole cascade, this chain reaction that can damage multiple structures within the shoulder.
Precisely. It's a really key insight from the biomechanics research. An adaptation, the posterior tightness that allows for increased external rotation needed for throwing, can become a pathological mechanism that directly leads to injury, like anterior stretching, the peel-back effect causing SLAP tears, and altered contact patterns contributing to cuff tears.
That's fascinating.
It's also worth noting, as the sources point out, that even with decreased internal rotation and the commonly seen increased external rotation in the dominant arm, the total arc of motion, adding IR and ER together, might actually remain the same as the non-dominant side. So it represents a complex adaptation, a shifting of the motion arc, rather than just a simple loss of motion.
That's a great insight into how the body adapts, but sometimes that adaptation clearly has negative consequences down the line. This whole biomechanical understanding really helps explain why certain injury patterns are so common in these athletes. Let's dive deeper into those specific injuries now, starting with the rotator cuff itself.
Right. Rotator cuff problems in overhead athletes really cover a spectrum, from simple tendinitis and those impingement symptoms we discussed, all the way to partial thickness and sometimes full thickness tears of the tendons.
Okay.
A key point experts make, though, is that the type of rotator cuff tear often seen in throwers is distinct from what you might typically see in, say, older, less active individuals with degenerative tears.
How so?
Because of the repetitive tensile overload during deceleration and that internal impingement mechanism we just discussed, the most common tears found in throwing athletes are partial thickness tears located on the articular side. That's the side facing inside the joint, the underside of the tendon.
Right, from that pinching during late cocking.
Exactly. These are often associated with internal impingement symptoms and sometimes underlying instability. In contrast, degenerative tears in older populations are more often full thickness and tend to start on the bursal side, the top side of the tendon. Another key difference is that rotator cuff tears in athletes can sometimes be secondary to underlying shoulder instability, which isn't usually the case in older degenerative tears.
And the symptoms an athlete might report if they have a rotator cuff issue.
Typically, it's diffuse shoulder pain, often poorly localized, but particularly bothersome during or after their overhead activity. They might notice weakness, especially with movements involving rotation or lifting the arm. And crucially for a thrower, a common complaint is a noticeable decrease in throwing velocity, or maybe a loss of control or endurance.
You mentioned SLA pairs being linked to that peel-back mechanism related to GRD. Let's talk a bit more about those specifically.
Okay, so SLAP stands for superior labral anterior posterior. These are tears that occur in the top portion of the labrum, that fibrous ring around the glenoid socket that helps deepen it and serves as an attachment site for ligaments and the biceps tendon.
Right, the rim cartilage.
Exactly. The superior labrum is precisely where the long head of the biceps tendon attaches, making this area particularly vulnerable to forces transmitted through the biceps, especially peeling or twisting forces during overhead motions like throwing. The incidence figures for SLAP tears reported in the literature vary quite a bit, maybe anywhere from 6% up to 26% in various surgical series looking at shoulder problems.
Is diagnosing a SLAP tear usually straightforward?
Actually, it can be quite challenging. One reason is that the anatomy of the superior labrum and exactly how the biceps anchor attaches to it is highly variable from person to person. There are normal variations like sublabral recesses or holes that can sometimes mimic a tear on imaging.
Okay, so MRI might be tricky.
It can be. This anatomical variability can make interpreting imaging like MRI or MRA difficult. Sometimes what looks like a tear might actually be a normal anatomical variant, like a sublabral foramen or the Buford complex. This is why arthroscopy, actually looking inside the joint with a camera during surgery, is often considered the gold standard for definitively diagnosing and classifying SLA tears.
So you can see it directly.
Exactly. During arthroscopy, the surgeon can visually inspect the labrum and, importantly, use a probe to physically assess the stability of the labrum and the biceps anchor. They can even reproduce that peel-back sign by positioning the arm in abduction and external rotation to see if the labrum actually lifts off the underlying bone, confirming instability.
So if the labrum peels away during that specific test inside the joint, that confirms the instability.
Yes, essentially it verifies that the labrum is detached and unstable in that critical throwing position. And as we discussed, SLAP tears don't usually happen in isolation. They are often associated with other issues like internal impingement, those partial articular-sided rotator cuff tears, sometimes underlying shoulder hyperlaxity, and that posterior capsule contracture related to GRD, often via that peel-back progression mechanism.
Okay. Beyond just tears in the labrum or the cuff tendons, overall shoulder instability is a major concern, particularly in young athletes, isn't it?
Absolutely. Shoulder instability exists on a spectrum. At one end, you have a frank dislocation, where the humeral head completely separates from the glenoid socket and usually needs to be put back in place.
Right.
Less severe is subluxation, which is a symptomatic partial translation of the humeral head on the glenoid. Maybe it shifts partway out, but then pops back in spontaneously.
Yeah.
Athletes might feel a clunk or a sudden sense of their shoulder giving out. Then there's apprehension, which is more of a feeling or fear of impending dislocation, often triggered when the arm is put in the specific position where they previously dislocated or subluxed classically. That 90 degrees abduction combined with 90 degrees external rotation position.
The throwing position again.
Exactly. And finally, clinicians sometimes describe the unstable, painful shoulder, where the main complaint might be pain during certain movements, particularly when tested for apprehension, but underlying that pain is evidence of instability or associated pathology like a labral tear causing the symptoms. And instability can be primary, the first time it happens, or very commonly in athletes, recurrent.
Recurrent instability sounds like it's just setting the stage for more and more problems down the road.
It definitely is. Recurrent anterior instability of the shoulder slipping forward is particularly common in young athletes, especially those involved in contact sports like football, rugby, or wrestling. And it has a notoriously high rate of happening again after the initial event, especially if treated non-operatively in that young high-risk group.
And each time it happens, it causes more damage.
Exactly. Each time the shoulder subluxes or fully dislocates, it can cause progressive damage to both the bone and the soft tissues. This includes bony damage. A Bankart lesion, which is essentially a fracture or wearing away of the bone on the front lower part of the glenoid rim where the labrum and capsule pull off.
Okay.
And a Hill-Sachs lesion, which is an impaction fracture or dent created on the back, outer part of the humeral head caused when it impacts against the front edge of the glenoid during the dislocation event.
How is the severity of that bone loss, say, on the glenoid, measured? Is there a threshold where it becomes really problematic?
Yes, experts use imaging like specialized X-rays, like the Bernigo view, or more accurately CT scans to assess the size and morphology of the Bankart lesion or the amount of glenoid bone loss. Significant glenoid bone loss is often considered when it's greater than about 6 millimeters wide or represents more than 20–25% of the total articular surface width of the glenoid, which is typically only about 24 millimeters wide to begin with.
So losing 25% is a big deal.
It's a very big deal for stability. Visually, during surgery, severe bone loss can make the normally oval-shaped glenoid look like an inverted pear, with the bottom front portion missing. For Hill-Sachs lesions on the humeral head, surgeons assess not just the size, but critically, whether the defect is engaging or off track.
Engaging, meaning it catches.
Yes, it means that as the arm rotates externally, the Hill-Sachs defect lines up with and actually catches or drops over the front edge of the glenoid, which dramatically increases the risk of future instability and often necessitates addressing the bone defect surgically.
And is there a way to predict the risk of the instability coming back even after surgery, say after a standard Bankart repair?
Yes, for anterior instability treated with an arthroscopic Bankart repair, which primarily fixes the soft tissues back to the bones, experts use scoring systems like the ISIS score. That stands for the Instability Severity Index score.
ISIS score.
It's a 10-point scale that incorporates several predictive factors. The athlete's age, being under 20, scores higher risk points. Whether they participate in competitive contact sports or sports involving forced overhead movements, if they have signs of generalized joint hyperlaxity, if they have a visible Hill-Sachs lesion on their pre-op X-rays, and if there's evidence of glenoid bone loss or erosion of the glenoid contour.
And a higher score means higher risk of it failing.
Exactly. A total score greater than 6 points on the ISIS scale is associated with a significantly higher risk, potentially around 70%, according to some studies of recurrent instability after an isolated soft tissue Bankart repair. This score is really valuable because it helps surgeons identify patients who might benefit from a more robust procedure, perhaps one that addresses bone loss up front, rather than just a soft tissue repair alone.
Makes sense. What about instability that's not just in one direction, like forward? Sometimes you hear about shoulders being loose all over.
Right, that's generally termed multidirectional instability, or MDI. It's often described by patients, quite simply, as loose shoulder. It means the shoulder is symptomatically unstable, feeling like it slips or shifts in more than one direction, commonly anteriorly forward, inferiorly downward, and sometimes posteriorly backward as well. MDI is usually linked to underlying factors like generalized capsular redundancy, meaning the joint capsule is naturally looser or more voluminous than average, or it could be part of a picture of constitutional hyperlaxity throughout the body.
Okay. Now, moving slightly away from the main ball and socket joint, what about problems up at the AC joint, where the collarbone meets the top of the shoulder blade?
Yes, the AC or acromioclavicular joint. Injuries here are extremely common, particularly in contact sports or activities where falls directly onto the point of the shoulder are frequent, football tackles, hockey checks, or falling off a bike. The usual mechanism is a direct force applied to the point of the shoulder, the acromion, while the arm is tucked into the side, adducted. This drives the acromion downwards and inwards relative to the clavicle collarbone, which is relatively stabilized by muscles and its connection to the sternum. This force causes tearing of the ligaments that support the AC joint, leading to varying degrees of separation.
And separate from those traumatic AC joint sprains, there's a specific bone issue that can affect the end of the clavicle in some athletes, particularly weightlifters.
Yes, that's distal clavicular osteolysis, or DCO. Experts in the sources particularly note the atraumatic form, ADCO, meaning it occurs gradually from overuse rather than a single traumatic event. It's reported as being surprisingly prevalent in dedicated weightlifters, with one study cited showing a 27% prevalence in that specific group.
Wow, over a quarter of them. What's happened to the bone?
It's characterized by chronic inflammation, stress reaction, and eventually degeneration or resorption of the bone at the very end of the collarbone, right where it articulates with the acromion. Imaging often shows changes like bone erosion, cystic changes, and inflammation. Sometimes there's even a direct communication seen between the distal clavicle changes and the AC joint itself. Importantly, it frequently occurs alongside Other shoulder problems like instability or impingement, kind of adding insult to injury and contributing to overall shoulder dysfunction and pain, especially with pressing movements.
Okay. And finally, one more structure around the biceps tendon, the long head specifically, which originates near the top of the shoulder socket. That can cause issues too.
Correct. The long head of the biceps tendon, or LHBT, runs in a groove, the bicipital groove, at the front of the humerus bone. Its stability within that groove relies on a complex sling-like arrangement of ligaments and tendon fibers, often referred to collectively as the biceps pulley system.
The pulley system. Okay.
This system is primarily formed by parts of the superior glenohumeral ligament, SGHL, the coracohumeral ligament, CHL, and also contributions from fibers of the uppermost subscapularis tendon and the anterior edge of the supraspinatus tendon. If this pulley system is injured, often due to trauma or associated with rotator cuff tears, the biceps tendon can become unstable. It can sublux, meaning partially slip out of the groove, or even fully dislocate from the groove.
Does the direction the biceps tendon moves, like forward or sideways, tell you something about which specific parts of that pulley system might be damaged?
Yes, it can provide important diagnostic clues. Experts describe different patterns of LHBT instability. It might sublux predominantly anteromedially, forward and towards the body, or maybe posterolaterally, or even just shift back and forth anteroposterior. The direction of instability can correlate with which specific components of the pulley system or which adjacent rotator cuff tendons, like the supraspinatus or subscapularis, are torn. For instance, an anteromedial dislocation of the biceps tendon is often strongly linked to a full-thickness tear of the supraspinatus tendon, and sometimes what are called hidden lesions involving tears of the deep fibers of the coracohumeral and superior glenohumeral ligaments, along with the very top part of the subscapularis tendon, which form that medial wall of the pulley. Understanding these specific patterns helps surgeons pinpoint the full extent of the damage during diagnosis and ensure all injured structures are addressed during surgery.
Okay, so from the extreme forces to the kinetic chain, the interplay of stabilizers, and these specific impingement patterns like GIRD and internal impingement, we can really see how the shoulder is uniquely vulnerable in overhead athletes. But, as you mentioned, the elbow also takes a tremendous beating in these sports. Let's shift our focus down the arm a bit. What are the most common elbow injuries we see highlighted in the sources for these athletes?
Well, one condition that's quite specific to the throwing elbow, particularly in younger athletes, adolescents maybe, is osteochondritis dissecans, or OCD, of the capitellum.
OCD of the capitellum. Okay, what's the capitellum?
The capitellum is that rounded bony knob at the end of the humerus, the upper arm bone, specifically on the outer or lateral side of the elbow. It's the part that articulates or forms a joint with the head of the radius bone in the forearm.
Got it. And what causes OCD there? Is it trauma?
The suspected mechanism in throwers isn't usually a single trauma, but rather chronic, repetitive, direct loading or compressive forces acting on the capitellum bone and its overlying articular cartilage. As the elbow goes through the throwing motion, particularly into extension and maybe some pronation, the radial head bone compresses up against the capitellum.
Okay.
Because this compressive force is applied repeatedly, at high velocity, and often with some valgus stress as well, specifically in the dominant throwing arm, it's thought to disrupt the delicate blood supply to the subchondral bone, the bone just underneath the cartilage surface. This can lead to a segment of bone and the overlying cartilage losing its blood supply, potentially softening, becoming unstable, and in some cases eventually loosening or even breaking off as a fragment.
And it's mostly just in the throwing arm.
Exactly. It's telling that this condition is reported as being very rare on the non-throwing side, strongly implicating those repetitive throwing mechanics.
What would someone actually see on imaging, like an X-ray or MRI, for OCD?
The findings on imaging vary a lot depending on the stage of the condition. Early on, it might just be a subtle area of decreased bone density or a small area of haziness, a translucency, seen on X-ray. As it progresses, you might see a more clearly defined fragment of bone, which could still be attached but unstable, non-displaced, or it might become completely detached and form a loose body floating within the elbow joint.
Ouch.
Imaging, especially MRI or sometimes CT orthography, is really critical not just for making the diagnosis, but also for staging the severity, looking at the integrity and health of the overlying articular cartilage, assessing whether the bone fragment is stable or unstable, and identifying any associated loose bodies. This staging is crucial for guiding treatment decisions.
Okay. Now, probably the most well-known elbow injury in throwing athletes, largely because of the surgery named after the baseball player, is the ulnar collateral ligament tear, the UCL tear.
Absolutely. The medial ulnar collateral ligament, or MUCL as it's often abbreviated, located on the inner side of the elbow, is the primary victim here. As we discussed when talking about valgus extension overload, the repetitive high-force valgus stress generated during the throwing motion puts tremendous tension specifically on this ligament complex, particularly its anterior bundle.
Right, that outward force on the forearm.
Exactly. Injuries to the UCL can happen acutely, maybe from a single, particularly forceful throw where the athlete feels a pop in immediate pain, indicating a sudden rupture of the ligament. But perhaps more often, these injuries occur on a background of chronic microtrauma.
So gradual wear and tear again.
Sort of. The ligament is progressively overloaded with each throw, sustaining multiple microscopic injuries over months or years. This leads to gradual attenuation, stretching, and degeneration of the ligament tissue. Eventually, this chronic damage can culminate in a partial or complete tear, sometimes with an acute event, like one bad throw, being the final straw that causes the already weakened ligament to fail completely.
What makes the MUCL so important biomechanically for the elbow? Why is it so critical for throwers?
It's the primary static stabilizer against valgus stress, particularly when the elbow is moving through the range of motion between about 30 and 120 degrees of flexion, which is exactly the range used during throwing. Without an intact and functional MUCL, the elbow joint would essentially be unstable and tend to gap open on the inside under the immense valgus forces of throwing.
But it's not the only thing providing stability on that side.
No, that's a very important point. It's not the only thing. The flexor pronator muscle group, which originates from the medial epicondyle right near the UCL attachment muscles like the flexor carpi ulnaris, FCU, and the flexor digitorum superficialis, act as critical dynamic stabilizers.
Dynamic, meaning the muscles help actively?
Yes. They contract powerfully, especially during the late cocking and acceleration phases of throwing, helping to actively resist that valgus force and thereby protect the passive ligamentous structure, the UCL. If these dynamic stabilizing muscles fatigue or are weak, then the static UCL structure has to take on even more of that valgus load, increasing its risk of injury.
Okay. Elbow dislocations, I assume, are usually more sudden and traumatic events compared to overuse UCL tears.
Yes, typically elbow dislocations are the result of a significant trauma, most often a fall onto an outstretched hand, what we often call a fouche injury. The mechanism usually involves some combination of axial load coming up the arm, a valgus force pushing the elbow inward, and often some degree of supination or palm-up twisting of the forearm.
And are there different types?
Yes, they can be classified as simple, meaning only the ligaments around the elbow are injured, or complex, which means there are associated fractures involved as well. Common fractures seen with complex elbow dislocations include fractures of the coronoid process of the ulna or the radial head.
What's the most critical thing to assess right after an elbow dislocation is put back in place, reduced?
Assessing the stability of the elbow joint after the reduction is absolutely crucial. The clinician will carefully move the elbow through a range of motion, often under fluoroscopy, live X-ray, to check for any signs of instability or resubluxation. A key finding, according to the sources, is that the elbow remains unstable and tends to sublux or even redislocate when it's flexed between approximately 45 and 60 degrees.
Why is that 45-60 degree range so important?
Because instability in that mid-range of flexion typically indicates severe ligamentous damage, often involving not just the medial side, UCL, but also disruption of the lateral collateral ligament complex, LCL, on the outside, which is critical for preventing posterolateral rotatory instability. This level of instability usually requires surgical intervention to repair the damaged ligaments and restore stability. Without adequate stability, you simply can't start the necessary early range of motion exercises needed to prevent debilitating long-term stiffness, which is a major risk after elbow dislocations.
Right. Stiffness is a big problem for elbows. And just revisiting VEO syndrome quickly, we talked about the posteromedial impingement aspect, the bone spurs, but it's also considered a syndrome of overuse itself, separate from an acute UCL tear.
Right. While the underlying mechanism involves those same valgus overload forces, VEO syndrome is really conceptualized as the chronic condition that develops over time from repetitive throwing. It manifests not just as potential medial elbow laxity due to stretching or microdamage of the MUCL over time, but also, very commonly, involves that painful posteromedial impingement. That's caused by the repeated forceful contact between the olecranon process of the ulna and the humerus during full extension, leading to inflammation and eventually the formation of those characteristic osteophytes, or bone spurs, in the back, inside part of the elbow. And as noted earlier, the symptoms from this posteromedial olecranon impingement related to VEO are reported as being a very common reason for elbow surgery in professional baseball players.
Okay, so we've covered the demanding mechanics and the resulting catalog of potential injuries in both the shoulder and the elbow. Now, how do clinicians actually piece all this together? How do they figure out exactly what's wrong with a specific athlete presenting with shoulder or elbow pain? What tools are in their diagnostic toolkit?
Well, the absolute foundation, the real cornerstone of diagnosis, is always starting with a thorough history and a comprehensive physical examination. You simply have to talk to the athlete and examine them carefully.
What kind of things in the history are most important?
You need to understand how the injury occurred. Was there a specific event, a pop, a fall, or did it come on gradually over time? What position was the arm in when it started hurting? Has this happened before? And then really drilling down on the exact nature and timing of their symptoms. When does it hurt? What makes it worse? What makes it better? Is the primary symptom pain? Is it instability, a feeling of looseness or giving way? Is it weakness? Is it stiffness? Where exactly is the pain located? Does it hurt during late cocking, during acceleration, during follow-through, after activity? All these details from the athlete's story are critical clues. Then comes the physical exam, where the clinician systematically looks at the shoulder and elbow, comparing it to the uninjured side. They'll assess active and passive range of motion, measure muscle strength, palpate carefully for specific areas of tenderness, and then perform a whole battery of specific clinical tests designed to stress or evaluate the integrity and function of different structures, ligaments, tendons, the labrum, joint stability. They'll also look for things like muscle atrophy or wasting or any visible asymmetry. And experts also stress the importance of evaluating the cervical spine, the neck, early on, especially if the pain is radiating, as pain from neck problems can sometimes be referred down to the shoulder or arm and mimic shoulder pathology.
Right, rule out the neck first. And there are dozens, maybe hundreds, of specific physical exam tests described for the shoulder, right? It seems quite complex.
There are many, and each is designed ideally to try and isolate or stress a particular structure or test a specific function. For example, the scapular pinch test assesses the strength and endurance of the scapular retractor muscles that control the shoulder blade. The sulcus test checks for inferior laxity or downward instability by pulling down on the arm and looking for a gap below the acromion.
Okay.
The clunk test, often performed with the arm overhead and being rotated, is one test used to try and detect certain types of labral tears or instability. The load and shift test is where the examiner manually tries to slide the humeral head forward and backward on the glenoid socket to assess the amount of anterior and posterior laxity or translation.
And the apprehension test.
The apprehension test, where the arm is passively moved into that provocative 90 degrees abduction and external rotation position, is key for assessing anterior instability. Does it reproduce the patient's feeling of instability or fear of dislocation? And the relocation test follows that, where the examiner applies a posterior force to the humeral head while in the apprehension position. If this pressure relieves the apprehension or pain, it further supports anterior instability as the cause.
What about testing the rotator cuff?
For the rotator cuff, tests like the liftoff test or the belly press test specifically assess the subscapularis tendon at the front. Resisted external rotation tests the infraspinatus anteris minor at the back, and tests like the empty can or full can test evaluate the supraspinatus tendon at the top. Although the specificity of some of these tests is debated, manual muscle testing quantifies strength in different planes.
And impingement tests.
Impingement tests, like the near sign, passively forcing the arm into forward elevation, and the Hawkins test, passively forcing the arm into internal rotation while elevated, aim to provoke pain by mechanically narrowing the subacromial space. The Yoakum test is another variation, and that hyperexternal rotation test we mentioned earlier specifically helps assess for posterior superior labral issues and internal impingement by stressing that extreme late cocking position.
You mentioned watching the scapula move earlier as being important. Is that formally part of the physical exam?
Oh, absolutely. Observational assessment of scapular kinematics, how the shoulder blade moves during arm elevation and lowering, is considered crucial. Clinicians look specifically for signs of scapular dyskinesis, abnormal movement patterns like excessive winging of the medial border or perhaps decreased upward rotation or maybe excessive shrugging during arm elevation.
And can you test if correcting the scapular motion helps?
Yes, a key diagnostic technique mentioned in the sources is using dynamic corrective maneuvers. This involves having the athlete perform the painful movement, like raising their arm, while the examiner manually assists in stabilizing or positioning the scapula correctly, for example, manually assisting upward rotation or preventing winging, like the sternal lift technique described. If the athlete's pain or symptoms significantly improve with this manual correction of the scapular motion, it strongly suggests that the abnormal scapular mechanics are a major contributing factor to their problem, which then directly guides the focus of rehabilitation.
That makes a lot of sense. And are there specific physical tests for the elbow that are highlighted?
Yes, for the elbow, careful palpation along the medial side for tenderness over the UCL attachment or over the posteromedial olecranon for VEO spurs is important. Palpating along the bicipital groove at the front of the shoulder down towards the elbow can sometimes reveal tenderness if there's biceps tendon involvement extending down, though as mentioned, it's not highly specific.
What about tests for the biceps or labrum originating near the shoulder but causing elbow symptoms?
Tests like O'Brien's test, resisted forward flexion with the arm internally rotated, Speed's test, resisted forward flexion with the palm up, and Yergason's test, resisted supination with the elbow flexed, are traditionally used to try and identify pathology involving the proximal biceps tendon or the superior labrum, SLAP tears. However, the sources note that these tests often have variable sensitivity and specificity and can be difficult to interpret reliably in isolation. Some experts suggest that combining tests, like performing the Speeds test along with an uppercut motion, resisted flexion with the fist moving towards the chin, might be somewhat better at differentiating true biceps pathology from SLAP tears, but it remains challenging clinically.
And testing the UCL, the Tommy John ligament.
For assessing the integrity of the critical ulnar collateral ligament, the primary test is the valgus stress test. This is performed with the elbow slightly flexed, usually around 20-30 degrees, to unlock the bony stability, and the examiner applies an outward-directed valgus force to the forearm while stabilizing the upper arm. They feel for any excessive gapping or laxity on the medial side compared to the uninjured elbow. The moving valgus stress test is another dynamic test where valgus stress is applied while the examiner moves the elbow through an arc of flexion and extension, looking to reproduce the athlete's specific pain or sense of instability often felt in a particular part of the range.
Okay, so beyond the crucial hands-on history and exam, imaging is usually the next step, providing that visual look inside. But as you hinted, different types of aging are best suited for looking at different things, right?
That's exactly right. Usually start with basic radiographs, standard x-rays. These are essential as a baseline for identifying any obvious bony abnormalities like fractures, including subtle Bankart rim fractures or Hill-Sachs impaction fractures, assessing the overall joint alignment, looking for signs of arthritis or degenerative changes, evaluating the AC joint for separation or arthritis. The Zanka view is specifically good for the AC joint, looking for loose bodies, bone chips floating in the joint, identifying osteophytes or bone spurs like in VEO, and helping to stage OCD lesions in the capitellum based on bony changes. X-rays are also crucial, of course, for confirming that an elbow dislocation has been properly reduced.
What if you need more detail on the bones, say, to measure the exact amount of glenoid bone loss after dislocations, or to get a better look at a complex fracture?
That's where CT scans, computed tomography, particularly with 3D reconstructions, become invaluable. CT provides the most detailed assessment of bony anatomy and is considered the gold standard for accurately quantifying the extent and morphology of glenoid bone loss and Hill-Sachs lesions. This information is critical for surgical planning, especially when considering bone augmentation procedures like the lateral jet. CT is also excellent for visualizing AC joint displacement in multiple planes and for assessing the changes seen in distal clavicular osteolysis. And 3D CT reconstructions are very helpful for planning surgery for complex OCD lesions, allowing the surgeon to really understand the shape and extent of the defect.
Okay, so CT for bone detail. What about the soft tissues, the ligaments, tendons, the labrum, the cartilage? What's the best imaging modality for those?
For soft tissues, MRI magnetic resonance imaging is generally the go-to modality. It provides excellent visualization of the rotator cuff tendons, showing tendinosis, partial tears, full tears, the labrum around the glenoid, the glenohumeral ligaments within the capsule, the joint capsule itself, and the articular cartilage covering the bone surfaces.
Is standard MRI always enough, or are there variations?
For detecting more subtle tears, especially the labrum or the ligaments, or small partial tears of the rotator cuff, MRA magnetic resonance arthrography is often preferred. This involves injecting gadolinium contrast dye directly into the joint before the MRI scan. The contrast fluid fills the joint space and, importantly, seeps into any tears or defects in the labrum, ligaments, or cuff tendons, making them much easier to see.
Ah, the dye highlights the tears.
Exactly. Experts in the sources often recommend direct MRA, injecting into the joint, as the diagnostic tool of choice for evaluating the rotator cuff and particularly the labrum in young athletic populations, as it significantly increases the sensitivity and diagnostic accuracy for these often subtle injuries compared to non-contrasted MRI. MRA is also very useful for assessing the integrity of the UCL in the elbow and for visualizing the status of the cartilage and detecting loose bodies in cases of OCD of the capitellum.
But even with MRA, you mentioned earlier that diagnosing SLAP specifically can still be tricky because of those normal anatomical variations.
Yes, that's a known limitation and a common challenge. Even with state-of-the-art MRI or MRA, it can sometimes be difficult for radiologists to definitively differentiate certain normal variations in the superior labrum and biceps anchor attachment, like a sublabral foramen or Buford complex, from a true pathological SLAP tear. This inherent ambiguity on imaging is one of the main reasons why arthroscopy, the minimally invasive surgical procedure where a small camera is inserted directly into the joint, is often still considered the gold standard for definitively diagnosing and classifying certain lesions, particularly SLA tears, and also for evaluating the cartilage surface in OCD of the capitellum.
So seeing is believing, essentially.
Pretty much. Arthroscopy allows the surgeon to directly visualize the structures in question, magnify them, and use a small probe to physically palpate them, assessing their stability and tissue quality. They can perform dynamic testing, like reproducing the peel-back sign for a sessilab tear, and directly assess the condition of the articular cartilage. It removes much of the ambiguity that can sometimes exist with imaging alone, although care must still be taken by the surgeon to distinguish true pathology from normal variants even during arthroscopy.
Are there any other imaging techniques commonly used?
Ultrasound is also mentioned as being used, particularly for certain applications. It has advantages like being relatively inexpensive, portable, can be done in the clinic, non-invasive, no radiation, and generally well tolerated by patients. Musculoskeletal ultrasound is particularly useful for evaluating rotator cuff tendon pathology, looking for tendinitis, calcifications, partial tears, or full tears. It's also very good for assessing fluid collections, like in the subacromial bursa.
Can it be used for treatment, too?
Yes, it's excellent for guiding injections accurately into specific locations like the subacromial space, the biceps tendon sheath, or the AC joint. It's also used by some clinicians to monitor the healing of rotator cuff repairs after surgery by visualizing the tendon integrity over time. And the sources also mentioned it can be helpful in assessing the superficial aspects of OCD lesions, although MRI is generally better for overall staging.
And you mentioned earlier incorporating the athlete's own perspective in the assessment process. How is that done?
Absolutely. Using patient-reported outcome measures, or PROMs, is increasingly recognized as being very important. The sources mention tools like the SINANE score, that's the single assessment numeric evaluation. It's very simple. The patient is just asked to rate their affected shoulder or elbow function on a scale from 0%, worst possible, cannot use the limb, to 100%, completely normal, pre-injury level.
Okay, just one number.
Just one number, giving a global sense of their perceived function. Another tool mentioned is the PSFS, the Patient-Specific Functional Scale. This one is more individualized. The athlete identifies up to 3 specific activities that are most important to them but are currently difficult due to their injury. Maybe it's throwing a baseball at full speed, swimming a specific stroke without pain, or lifting a certain amount of weight overhead.
Right, things relevant to them.
Exactly. Then they rate their current ability to perform each of those specific activities on a scale of 0, unable to perform the activity at all, to 10, able to perform the activity at their pre-injury level without any difficulty. These tools are valuable because they directly capture the patient's subjective experience and their perceived functional limitations, which are vital pieces of the puzzle, especially early in the diagnostic process and for tracking progress over time.
Okay, so putting it all together, the detailed history, the thorough physical exam with all those specific tests, the targeted imaging like X-ray, CT, MRI, or MRA, maybe ultrasound, and getting the athlete's own functional rating clinicians can usually arrive at a pretty accurate diagnosis. What are the next steps then? Treatment. When is trying non-operative management, without surgery, the right path to start on?
Non-operative treatment is typically the first line of management attempted for many, if not most, shoulder and elbow conditions in athletes, especially those that seem to be related to chronic overuse or involve less severe structural damage that doesn't necessarily require surgical repair to heal or become stable. This would include conditions like rotator cuff tendinitis, milder forms of shoulder impingement, both subacromial and internal, chronic distal clavicular osteolysis, DCO, lateral epicondylitis, tennis elbow in the elbow, and critically, as we mentioned, most initial cases of multidirectional instability, MDI, or general shoulder looseness.
What does that conservative non-operative treatment usually involve?
The core components generally include a period of relative rest and significant activity modification. This means substantially reducing or temporarily stopping the specific activity or movements that provoke the pain, like throwing, swimming, or heavy lifting.
Okay, stop irritating it.
Exactly. NSAIDs, non-steroidal anti-inflammatory drugs like ibuprofen or naproxen, are often used for a short course to help manage pain and reduce inflammation, although their long-term use is generally discouraged. Injections can sometimes play a role in providing temporary relief and aiding rehabilitation. Corticosteroid combined with local anesthetic injections can be targeted to specific areas like the subacromial space for impingement, the AC joint, or around inflamed tendons to calm down inflammation and break the pain cycle.
What about other types of injections like PRP?
The sources mention other types of injections like hyaluronic acid, viscosupplementation, or platelet-rich plasma, PRP, but they also note that the evidence supporting their effectiveness, particularly for many shoulder and elbow conditions, is still somewhat debated or evolving, and they aren't universally recommended as first-line treatments based on the material presented. For certain elbow issues like MUCL sprains or during recovery from VEO, bracing might be used, for instance. A hinged elbow brace that limits full extension might be employed to provide support and protect the healing tissues during activities.
And physical therapy, I assume, is absolutely central to any non-operative approach.
Absolutely. Physical therapy or physiotherapy is paramount. It's really the cornerstone of effective non-operative management. The specific goals are always tailored to the individual athlete and their specific injury, but broadly speaking, PT focuses on several key areas.
Such as?
Restoring normal, pain-free range of motion is often a primary goal. Improving flexibility is crucial, especially addressing any specific tightness identified, like that posterior capsule contracture contributing to GRD in throwers. Strengthening the key muscle groups responsible for stability and controlled motion is vital. This includes the rotator cuff muscles, the scapular stabilizing muscles like the serratus anterior, rhomboids, trapezius, and importantly, strengthening the core and lower body musculature to improve the efficiency of that entire kinetic chain.
Right, fix the chain.
Exactly. And enhancing neuromuscular control and coordination, essentially retraining the brain and muscles to work together smoothly and efficiently, is also a major focus. Specific stretching techniques mentioned in the sources include the cross-body stretch, the sleeper stretch, lying on the side and internally rotating the arm, and other internal rotation or horizontal adduction stretches, all designed to target that posterior shoulder tightness associated with GRD. For elbow conditions like lateral epicondylitis, tennis elbow, eccentric training protocols, which focus specifically on the muscle's ability to lengthen under load, have demonstrated particularly good results in research.
Can you get a sense during that initial assessment phase if someone is likely to respond well to just physical therapy and conservative care, or if they're probably heading towards surgery eventually?
For certain conditions, yes, there might be some predictive factors. For instance, experts note that for internal impingement of the shoulder, certain findings during the physical examination can help predict the likelihood of success with non-operative management. These might include the specific pattern of pain reproduction with resisted arm movements, like abduction or forward flexion, the athlete's baseline scapular position and their ability to control it during arm motion, and perhaps their ability to sustain rotator cuff strength, particularly at 90 degrees of abduction. If these factors look favorable, the prognosis with rehab might be better.
And for MDI, that generalized loose shoulder. You mentioned earlier that therapy is strongly recommended as the primary approach there.
Yes, absolutely. For multi-directional instability, the sources emphasize that non-operative treatment, focusing intensely on strengthening the dynamic stabilizers, the rotator cuff and the scapular muscles, and improving neuromuscular control and proprioception, is strongly recommended as the primary treatment strategy. The goal is to improve the muscular control and stability around the joint to compensate for the underlying capsular laxity. Experts explicitly state in the material that thermal capsulorrhaphy, an older surgical technique that used radiofrequency heat to try and shrink the redundant joint capsule, is not recommended for MDI due to unacceptably high rates of failure, recurrence of instability, and potential complications like nerve injury or cartilage damage. So PT is really the mainstay for MDI.
Okay. So non-operative treatment is often the starting point, especially for overuse issues or less severe injuries. When does surgery become the necessary or recommended option?
Surgery is typically considered when a well-structured and compliant non-operative treatment program fails to adequately relieve the athlete's symptoms and restore their desired level of function after a reasonable period, usually at least 3 to 6 months. Or surgery might be indicated more acutely if the injury involves significant structural damage that is unlikely to heal on its own and poses a clear risk of ongoing instability, progressive damage, or functional limitation.
Like what kind of injury?
This would include things like asymptomatic large partial thickness, greater than 50% thickness, or full thickness tears of the rotator cuff tendons, especially in younger, active individuals. It includes significant shoulder instability, particularly traumatic anterior dislocations in young, high-risk athletes that keep recurring despite attempts at rehabilitation. Symptomatic bony lesions that cause mechanical problems, like large engaging Hill-Sachs defects or significant glenoid bone loss, often require surgical correction. Unstable OCD lesions in the elbow with loose fragments usually need surgery. And complete tears of critical ligaments, like the elbow UCL, that result in functional instability and don't respond adequately to conservative care, are also common surgical indications in athletes.
Let's go through some of the specific surgical procedures mentioned for the shoulder, starting again with the rotator cuff tears in athletes. What are the typical options there?
The surgical options really depend on the specific characteristics of the tear, its size, thickness, location, and the quality of the tendon tissue. For smaller partial thickness tears, say less than 50% of the tendon's thickness, particularly if they are causing impingement symptoms, an arthroscopic debridement might be performed. This essentially involves shaving or cleaning up the frayed edges of the tear without actually repairing it.
Okay.
For larger partial thickness tears, generally considered more than 50% thickness, or for full thickness tears where the tendon is completely torn through, surgical repair is usually indicated, especially in active individuals. This typically involves reattaching the torn tendon back down to its bony insertion site on the humerus, the greater tuberosity. This can usually be done arthroscopically using suture anchors placed into the bone. Occasionally, for very large or complex tears, a mini-open technique might be used.
Is anything else done at the same time, like addressing impingement?
Sometimes an acromioplasty, which involves shaving down some bone from the underside of the acromion, the bone forming the roof of the shoulder, might be performed concurrently, particularly if there are clear signs of subacromial impingement, like a bone spur, or associated changes in the coracoacromial ligament contributing to the problem. However, the routine use of acromioplasty, especially in the context of tears primarily caused by internal impingement or instability in athletes, is somewhat debated among surgeons.
Are there specific repair techniques mentioned for larger tears?
Yes, experts mention advanced arthroscopic techniques like the MPTOE repair, which stands for medial portal transosseous equivalent. This is often used for full-thickness tears that are larger than about 10 millimeters in size. The goal of this technique is to create a stronger and more anatomical repair interface by using suture anchors placed both medially closer to the joint surface and laterally on the bone footprint, creating a broader area of tendon-to-bone compression that better mimics the natural tendon insertion and potentially improves biomechanical load sharing.
Sounds complex. Are there downsides?
Like any technique, it has potential pitfalls. The sources mention concerns like potential failure of the medial row anchors if not placed securely, or a possible purse string effect where over-tightening the sutures could constrict blood flow to the tendon edge. But regardless of the specific repair technique used, a critical point that experts emphasize repeatedly is that athlete noncompliance with the lengthy and strict post-operative rehabilitation protocol is a major risk factor for surgical failure and re-tear, even if the initial repair was technically perfect.
Rehab is key. Now, what about surgery for those tricky SLA tears we discussed? When is that done and how?
Surgery for SLP tears is generally considered for symptomatic, unstable tears, typically those classified as type 2, where the superior labrum and biceps anchor are detached from the glenoid rim, or more complex types, especially in athletes who haven't improved sufficiently with a course of physical therapy focused on addressing associated issues like GRRD or scapular dyskinesis.
And what does the surgery involve?
The standard procedure involves arthroscopically repairing the torn labrum back to the bone. The surgeon will first debride, or clean up, the frayed edges of the torn labrum, and then prepare the bony surface of the glenoid rim underneath it to create a bleeding surface that promotes healing. Then, small suture anchors, loaded with strong sutures, are placed into the bone along the glenoid rim. These sutures are then passed through the torn labrum and the base of the biceps anchor and tied down securely, compressing the labrum back onto the prepared bone bed.
Are there any nuances in how the repair is done?
Yes, surgeons often prefer using multiple smaller anchors rather than fewer larger ones to create a broader area of fixation. They are also typically careful about anchor placement, particularly avoiding placing anchors too far anteriorly and superiorly, as this could potentially overconstrain the biceps tendon or alter its normal excursion, leading to postoperative stiffness or pain. And critically, if there are any other associated injuries found during the arthroscopy, like other labral tears elsewhere around the rim or concurrent rotator cuff tears, those are usually repaired during the same surgical procedure.
Is repair always the answer for SLAP tears? What about that biceps tenodesis you mentioned?
Biceps tenodesis, which involves detaching the long head of the biceps tendon from its origin on the superior labrum and reattaching it surgically to the humerus bone lower down, outside the joint, is presented as a viable alternative option in certain situations. It might be considered for failed SLAP repairs, for SLA tears that extend significantly into the biceps tendon itself, classified as type 40 tears, or often in older athletes, say over 40, where the SLA tear might be more degenerative in nature and the primary pain generator might be the biceps tendon itself rather than just the labral instability.
Okay. And for contact athletes with both instability and a SLAP tear?
For contact athletes presenting specifically with anterior shoulder instability and a concomitant SLAP tear, some experts mention in the sources advocate for earlier arthroscopic intervention to repair both the anterior labrum, Bankart lesion, and the SLAP lesion simultaneously, along with addressing any other associated injuries found, aiming for a quicker and more stable return to their high-demand sport.
Makes sense. Now, how about the surgical approaches for shoulder instability itself, especially when there's that significant bone loss we talked about? A simple Bankart repair isn't always enough then.
That's correct. For anterior shoulder instability, that is primarily due to soft tissue damage, a tear of the anterior labrum and stretching of the capsule, a Bankart lesion, and where there is minimal or no significant glenoid bone loss, generally considered less than 20–25%, a standard arthroscopic Bankart repair is often the procedure of choice. This involves using suture anchors, similar to a SLAP repair, to reattach the torn labrum and tighten the stretched anterior capsule back to the front rim of the glenoid.
But when there is significant bone loss,
When there is significant glenoid bone loss, more than 20–25%, or a large engaging Hill-Sachs lesion on the humeral head performing just a soft tissue percent, Bankart repair alone has been shown to have a very high failure rate, with recurrent dislocations being common, particularly in young, active athletes playing contact or collision sports. In these situations, osseous reconstruction procedures, surgeries that address the bone deficiency, are often necessary to restore stability.
what kind of procedures?
The Latarjet procedure is perhaps the most well-known and commonly performed for significant anterior glenoid bone loss. It involves surgically transferring the coracoid process, which is a bony projection from the front of the scapula that has strong muscles attached to it, and fixing it onto the deficient anterior glenoid rim. This does two things. It creates a bony buttress that physically blocks the humeral head from dislocating forward, and the transferred muscles also provide a dynamic sling effect when the arm is abducted and externally rotated, further enhancing stability.
Okay, the Latarjet for glenoid bone loss. What about the Hill-Sachs lesion on the humeral head?
For large Hill-Sachs lesions that are deemed to be engaging but maybe occur in the setting of less severe glenoid bone loss, a procedure called remplissage might be performed, often in conjunction with an arthroscopic Bankart repair. Remplissage involves arthroscopically suturing the posterior rotator cuff tendon, infraspinatus, and the posterior capsule into the Hill-Sachs affect on the back of the humeral head. This effectively fills the defect and prevents it from catching or engaging on the front edge of the glenoid during external rotation. For cases with severe bone loss on both the glenoid and humeral head, more complex bone grafting procedures using bone taken from the patient's iliac crest, hip bone, or allograft, donor bone, might be required. These osseous reconstructions generally require a different, often more cautious rehabilitation approach compared to simple soft tissue repairs.
Okay, and quickly, what about surgery for severe GRD or DCO if conservative treatment fails?
Yes, for significant GRD that remains symptomatic and restrictive despite dedicated stretching and physical therapy, a surgical posterior capsular release can be performed arthroscopically. This involves carefully cutting or releasing the thickened posterior capsule to restore more normal internal rotation range of motion. Studies cited have recorded significant increases in internal rotation gained after this procedure. And for distal clavicular osteolysis, a DCO, that continues to be painful and limit function despite rest, activity modification, and other conservative measures. Surgical resection of the very distal end of the clavicle, usually the outer 5-10 millimeter, is performed to remove the damaged, inflamed bone and decompress the AC joint. An arthroscopic approach, often done through the subacromial space, is frequently preferred by surgeons for this, allowing for quicker recovery compared to an open approach.
All right, now shifting down to elbow surgery. What are the surgical options outlined for OCD of the capitellum, that bone and cartilage issue?
Surgical treatment for OCD of the capitellum is really dependent on the stage of the lesion, particularly its stability and the condition of the overlying cartilage. For very early, stable lesions where the cartilage is intact, continued non-operative management might still be attempted, sometimes with adjuncts like lipus, low-intensity pulsed ultrasound, which some research mentioned in the sources suggests might potentially help shorten the natural healing or repair period, although evidence is limited.
But if it's unstable or loose?
For unstable lesions, or those with detached or loose fragments, or lesions that have failed to heal with non-operative care, surgery is usually necessary. Several options exist. Arthroscopic drilling or microfracture involves creating small holes in the underlying bone within the defect to stimulate bleeding and hopefully promote some fibrocartilage healing. However, the sources suggest this has limited indications, maybe only for very small, contained, early-stage lesions.
What about filling the defect?
Bone peg grafts are a technique described where small cylindrical plugs of bone, often harvested arthroscopically or through a small incision from the patient's own olecranon process, the bony point at the back of the elbow, are used to fill the bony defect beneath the unstable cartilage lesion, providing structural support. The harvest site in the olecranon typically regenerates bone over time. Osteochondral mosaicplasty is another option, particularly for slightly larger defects, where plugs of healthy bone and its overlying cartilage are harvested from a less critical non-weight-bearing part of the patient's knee, or sometimes the elbow itself, and transplanted into the capitellar defect, like laying mosaic tiles.
What if the lesion is really large?
For large, extensive OCD lesions, especially if there's significant cartilage damage and perhaps early secondary osteoarthritis developing, more complex reconstructive procedures like costal osteochondral grafts might be considered. This involves harvesting a larger piece of cartilage and underlying bone from one of the patient's ribs and shaping it to fit the defect. The sources mention a case example where delayed treatment of a large OCD lesion led to significant osteoarthritis, highlighting the importance of timely intervention for better outcomes.
Okay. And the famous Tommy John surgery for the UCL tear in the elbow, what does that involve?
Right, ulnar collateral ligament reconstruction, often called Tommy John surgery, is performed for athletes, most famously baseball pitchers, who have significant medial elbow instability due to a complete or high-grade partial tear of the MUCL that has not responded adequately to non-operative management and prevents them from throwing effectively. The indication is usually based on clinical exam findings, laxity with valgus stress, especially between 45-60 degrees, and confirmed by imaging like MRA.
How is the ligament reconstructed?
The goal is to reconstruct the torn ligament using a tendon graft to replace it. The most commonly used graft source is the palmaris longus tendon, a small tendon in the patient's own forearm, which is functionally redundant for most people. If that's not available or suitable, other options include using a portion of a hamstring tendon from the leg, or sometimes using an allograft tendon from a cadaver donor, like the Achilles tendon. Various surgical techniques exist to secure the graft tendon across the medial elbow joint, drilling tunnels in the humerus and ulna bones in the location of the original UCL attachment points. Common techniques mentioned include the original Jobe technique, often using a figure-of-8 graft passage, or newer techniques like the Dane TJ, which use interference screws for fixation in the bone tunnels.
What about the ulnar nerve, which runs right near there?
That's a critical consideration. The ulnar nerve runs in a groove just behind the medial epicondyle, very close to the UCL. Historically, the ulnar nerve was often routinely transposed, surgically moved to a different position, usually more anteriorly during Tommy John surgery, to prevent potential irritation or scarring around the nerve from the surgery itself. However, experts in the sources now generally recommend selective ulnar nerve transposition. This means the nerve is only moved if it was already symptomatic before surgery, if it shows signs of instability, subluxing out of its groove, or if it seems clearly at risk during the ligament reconstruction. This selective approach aims to avoid the potential complications associated with nerve transposition itself, such as neuropraxia, nerve bruising or temporary dysfunction, or persistent nerve symptoms.
Okay. And for those unstable elbow dislocations after they've been reduced, what's the surgical approach?
If the elbow remains significantly unstable, particularly in that 45–60 degree flexion range, after closed reduction, surgical repair of the disrupted ligaments is usually indicated. In the common posterolateral dislocation pattern, the lateral collateral ligament, LCL complex, is often the primary structure injured and requires repair back to its attachment on the humerus to restore stability against gravity and prevent recurrent subluxation. The medial collateral ligament, MUCL, may also be injured and require repair, especially if there's significant valgus instability as well. The goal of surgical repair is to restore enough static stability to allow for early controlled range of motion exercises to begin shortly after surgery.
Why is early motion so important?
Because the elbow joint is notoriously prone to developing severe stiffness and contracture if it's immobilized for too long after an injury or surgery. Achieving stability that permits early motion is absolutely critical for preventing long-term functional deficits. In rare cases of severe instability where even ligament repair doesn't provide adequate stability, temporary external fixation using a frame outside the arm connected by pins drilled into the humerus and ulna might be used for a few weeks to hold the joint in a reduced position while the soft tissues begin to heal, allowing for some controlled motion through the fixator hinge if possible.
And finally, surgery for VEO syndrome, those bone spurs causing impingement.
Surgical treatment for symptomatic valgus extension overload syndrome typically involves arthroscopic debridement. The surgeon uses minimally invasive techniques to go into the back of the elbow joint and remove the problematic osteophytes, bone spurs, from the posteromedial aspect of the olecranon process, and also remove any loose bodies within the joint that might be causing mechanical symptoms like clicking or locking. The goal is to relieve the impingement. Importantly, if the chronic valgus stress that led to the VEO has also resulted in a significant symptomatic tear or insufficiency of the MUCL, then UCL reconstruction is often performed at the same time as the spur removal to address the underlying instability component as well.
Okay, so that covers the main surgical options. Now, whether an athlete has had surgery or has been managed non-operatively, the recovery process, the rehabilitation phase seems like it's absolutely crucial for getting back to sport.
It cannot be stressed enough. Rehabilitation is not just some passive part of the treatment. It is arguably the most critical phase for determining the ultimate success of the intervention. Experts in the sources consistently highlight that athlete non-compliance with the prescribed rehab program, or trying to rush the process, is a major risk factor for failure, re-injury, or a suboptimal outcome, regardless of whether the initial treatment was surgical or non-surgical.
What are the general principles guiding that rehab process? It must be carefully structured.
Yes, rehabilitation almost always follows a structured, phased approach, with progression based on meeting specific criteria related to healing time, pain levels, range of motion, strength, and functional ability, rather than just following a strict calendar timeline. Typically, it's divided into phases like the acute early protection phase, the intermediate strengthening and neuromuscular control phase, and the advanced or return to play phase.
What happens in that early acute phase?
The primary goals in the acute phase are to protect the injured or surgically repaired structures, control pain and swelling using things like ice, compression, elevation, and initiate gentle, controlled range of motion exercises to prevent stiffness and maintain joint health. Early range of motion is particularly critical for the elbow after dislocation or surgery to try and prevent the development of debilitating stiffness. Slings are commonly used for support and protection after shoulder injuries or surgery. Sometimes specific types like external rotation slings are used after certain rotator cuff or instability repairs to offload the repaired tissues. Hinged elbow braces are frequently used after elbow surgery, like UCL reconstruction, or complex dislocations to allow controlled motion within a safe range while protecting the healing ligaments.
What kind of exercises are typically involved in these different phases?
In the acute phase, basic exercises might include simple passive pendulum swings for the shoulder to encourage joint fluid movement without muscle activation, gentle passive or active assisted range of motion exercises within protected limits, and maybe isometric exercises, muscle contractions without joint movement. Specific stretching techniques might be introduced early on to regain lost motion or address identified tightness, like those sleeper stretches or internal rotation stretches for posterior capsule tightness in the shoulder.
And as they progress?
As the athlete progresses to the intermediate phase, the focus shifts towards gradually restoring full range of motion and initiating strengthening exercises. This usually starts with low resistance, using elastic bands or light pulleys, targeting the rotator cuff muscles, external rotation, abduction, the deltoid, and critically, the scapular stabilizing muscles, exercises like rows, protraction, retraction. More advanced strengthening in the later intermediate and advanced phases involves progressively increasing resistance and complexity, incorporating exercises like seated cable rows, various push-up progressions, starting against a wall, then incline, then floor, dumbbell exercises like flies or presses carefully introduced, and more challenging tubing or cable exercises targeting different muscle groups and movement patterns.
What about the rest of the body?
Crucially, throughout all phases, rehabilitation should incorporate core strengthening exercises and lower body exercises like squats, lunges, and gluteus activation exercises. Remembering that kinetic chain concept, a strong and stable core and lower body are essential for efficient energy transfer and reducing stress on the throwing arm. Addressing specific muscle imbalances identified during the assessment, like tightness in the pectoralis minor muscle, which can pull the scapula forward and contribute to altered mechanics, is also an important part of comprehensive rehab.
And specifically for the throwing athlete who wants to get back on the mound or the tennis court or into the pool, the rehab must become very sport-specific towards the end.
Absolutely. The final phases of rehabilitation must become progressively more sport-specific to prepare the athlete for the unique demands of their activity. Key principles reiterated by the experts for throwing athletes include maintaining the necessary functional range of motion, which might even include preserving some of that adapted GRD pattern, increased ER, decreased IR, seen in their dominant arm, as long as the total arc of motion is symmetrical to the non-dominant side and they have good control. Ensuring excellent muscle balance, strength, and endurance throughout the entire kinetic chain is paramount. And achieving high levels of neuromuscular control and proprioception, the joint sense of position, is critical for coordinated, efficient movement.
What does that look like in terms of exercises?
The intermediate phase often involves building strength and power through both open chain, hand-foot free, and closed chain, hand-foot fixed exercises, and starting to introduce basic plyometric exercises like medicine ball throws, rebounder work, to retrain explosive power and reactive muscle firing. The advanced phase is where the athlete truly prepares for a return to their sport. This involves progressing from light activity to increasingly intense sport-specific drills, like initiating an interval throwing program for baseball players or specific stroke drills for swimmers.
And scapular control remains important throughout.
Yes. Experts emphasize that optimizing scapular control and ensuring proper scapulohumeral rhythm, the coordinated movement of the scapula and humerus, should be a key determinant for deciding when an athlete is ready and safe to begin a return-to-play throwing or overhead activity program. The goals for clearing an athlete to return to sport typically include achieving full, pain-free range of motion, demonstrating strength and endurance that's close to their baseline, or the uninjured side, often measured isokinetically, having static stability on clinical testing, and exhibiting smooth, well-controlled movement patterns during functional activities and sport-specific movements.
Okay. So after going through potentially months of this entire process diagnosis, maybe surgery, definitely lengthy rehab, the ultimate question for the athlete is, when can I actually get back to competing? And maybe more importantly, what are the chances of me returning to the same level I was at before the injury?
Yeah, that's a million-dollar question for every injured athlete. And the answer is that return-to-play timelines vary significantly based on a lot of factors. The specific injury, the type of treatment they had, surgical versus non-surgical, and which specific procedure, the demands of their particular sport, their level of competition, professional versus recreational, and individual factors like age, adherence to rehab, and biological healing response. It's rarely a quick process, particularly after major surgery for significant structural injuries.
Are there some typical timelines mentioned in the sources for common procedures that give us a ballpark idea?
Yes, they do provide some examples, but these should be seen as general guidelines. For instance, after a SLAP repair surgery, return to contact sports might be possible around the 3-month mark. But for repetitive overhead athletes like pitchers or swimmers, returning to full sport activity typically takes much longer, often cited as being over 6 months. And the sources note that patient satisfaction rates after SLAP repair can sometimes be lower for chronic tears compared to acute traumatic tears.
What about rotator cuff repairs?
For rotator cuff repairs, especially in elite athletes like professional baseball pitchers, the outlook can be more guarded. Experts point out that reported return-to-play rates back to their pre-injury elite performance level have historically been somewhat poor, although surgical techniques and rehab protocols are continually improving. Osseous shoulder reconstructions, like the Letarjet for bone loss, might allow a return to some activities around 2-3 months, but returning fully to contact sports likely takes longer, maybe 6 months or more. Similarly, posterior shoulder instability repair aiming for return to contact sports is often targeted around the 6-month mark.
Any faster returns?
Limited surgical resection for distal clavicular osteolysis is one of the procedures with a potentially faster return, with athletes possibly resuming training within just 1 to 2 weeks if symptoms allow. UCL reconstruction, the Tommy John surgery, generally reports high rates of return to play overall, but the time frame is notoriously lengthy, often taking 12 months or even longer for pitchers to get back to competitive pitching. Arthroscopic treatment of VEO syndrome, removing those bone spurs, also shows generally satisfactory results and high return rates mentioned in the sources, perhaps around 4 to 6 months on average.
Are there factors that help predict who will do better or worse in terms of returning to play?
Yes, some prognostic factors are mentioned. For SLIP tears, having other simultaneous injuries identified during surgery, like a concurrent rotator cuff tear or additional labral damage elsewhere, are generally considered negative prognostic factors associated with potentially less successful outcomes or a more difficult return. For anterior shoulder instability treated with a standard Bankart repair, that ISIS score we discussed earlier is a valuable tool for predicting the risk of redislocation, which obviously impacts the ability to return safely to high-risk activities. A higher ISIS score predicts a higher chance of failure and may influence the initial surgical choice or counseling about return to sport.
It sounds like while the science and the surgical techniques and the rehab protocols are incredibly advanced, the road back to peak elite performance can still be a really significant challenge for some athletes, depending on the specific injury and the demands of their sport.
It absolutely can be. Managing the cumulative effects of chronic microtrauma versus a single acute injury, dealing with the complexities of certain surgical procedures, and avoiding potential complications like nerve issues after some elbow surgeries or stiffness or hardware problems after certain shoulder bone procedures, and simply regaining the highly fine-tuned neuromuscular control, confidence, and power required at the elite level after a major structural injury are all ongoing challenges in sports medicine. It's not always straightforward.
This deep dive has really highlighted the incredible, almost violent demands placed on the shoulder and elbow in overhead sports, showing us exactly why these specific and often complex injury patterns occur. We've navigated through the diverse ways these injuries are diagnosed, explored the wide range of non-operative and surgical treatment strategies available, and underscored the absolutely non-negotiable importance of a dedicated, structured, and highly tailored rehabilitation program to even have a chance at successfully getting back on the field, court, or in the pool.
It really gives you a profound appreciation for the remarkable engineering of the human body, capable of generating such forces and velocities, but also its inherent limitations when pushed consistently to its absolute physical edges. And it highlights the constant evolution of the science and medicine dedicated to understanding these limits, helping athletes recover, and hopefully finding better ways to prevent these injuries from happening in the first place.
And thinking about the sheer magnitude of those forces, the way chronic microtrauma seems to inevitably build up over time in many athletes, the way the body sometimes adapts in ways that seem helpful but actually become harmful, like GRD leading to peel back, and the fact that even with the very best treatment available today, returning to that pre-injury elite performance level isn't always a guarantee. It definitely leaves you with a provocative thought, doesn't it?
It certainly makes you wonder, in this relentless pursuit of maximizing athletic performance, pushing boundaries harder, faster, stronger, are these kinds of debilitating joint injuries simply an inevitable trade-off, the unfortunate but accepted cost of competing at the highest levels in these overhead sports?
Or is it possible that a truly perfected understanding of individual biomechanics, maybe combined with predictive analytics, personalized prevention strategies, and even more advanced biological treatments in the future, could one day fundamentally shift that balance? Could we reach a point where athletes can achieve these incredible feats of power and precision without necessarily paying such a heavy, long-term physical toll on their shoulders and elbows? It's a fascinating and critical question for the future of sports and the long-term health of these dedicated athletes.